Welcome to NSG 323, Study Session 13, Normal Puerperium. Introduction. Puerperium is the first 6 weeks after delivery, during which the body readjusts back to the period before pregnancy. In this unit, the care of the woman during puerperium shall be discussed. There will also be a review of infant welfare, clinic, and family planning. Learning outcomes. After the study, you should be able to explain the analysis process of involution of the uterus, discuss the overview of the relevant anatomy and physiology in the postpartum period, highlight the natural method of menstrual cycle, mention the physiological changes during the period of puerperal problems, elaborate on postnatal care. Analysis, the process of involution of the uterus. Discuss the well-being of women after delivery with recognition when the lochial discharge is becoming abnormal. Guide women in making informed choice on a method of family planning and list family planning methods. Puerperium is defined as a period which commences after the expulsion of the placenta and lasts up to about 6 to 8 weeks after delivery. It is characterized by physiological and psychological changes when the reproductive organs return to their pre-gravid state, lactation is initiated and established, and there is recuperation from physical and emotional experiences of pregnancy and delivery. The foundations of the relationship between the mother and the infant are laid. The mother assumes the responsibility for care and nurturing of her infant. The process by which the generative organs return to their pre-gravid state is known as involution. An overview of the relevant anatomy and physiology in the postpartum period. Uterus. The pregnant term uterus, not including baby, placenta fluids, etc., weighs approximately 1000 g. In the 6 weeks following delivery, the uterus recites to a weight of 50 to 100 grams. After delivery of the placenta, the uterus is at the size of 20-week pregnancy, but reduces in size on abdominal examination by 1 finger breadth each day, such that on the 12th day it cannot be palpated, at which time the uterus has shrunk enough to return to the true pelvis. By end of puerperium, it is only slightly larger than pre-pregnancy. Uterus of human body. The endometrial lining rapidly regenerates so that by the 7th day, endometrial glands are already evident. By the 16th day, the endometrium is restored throughout the uterus, except at the placenta site. The placental site undergoes series of changes in the postpartum period. Immediately after delivery, the contractions of the arterial smooth muscle and compression of the vessels by contraction of the myometrium, physiologic ligatures, result in hemostasis. The size of the placenta bed decreases by half, and the changes in the placenta bed result in the quantity and quality of the lochia that is experienced. Immediately after delivery, a large amount of red blood flows from the uterus until the contraction phase occurs. Thereafter, the volume of vaginal discharge, lochia, rapidly decreases. The duration of this discharge, known as lochial rubra, is variable. For the first 3 to 4 days, lochia comprises mainly blood and remnants of thromboblastic tissue. The red discharge progressively changes to brownish red, with a more watery consistency, lochia serosa. Over a period of weeks, the discharge continues to decrease in amount and color and eventually changes to yellow, lochia alba, The period of time the local can last varies, although it averages approximately 5 weeks. Special organ of a pregnant woman. The following are special organs of pregnant women. 1. Cervix. The cervix also begins to rapidly revert to a non-pregnant state, but it never returns to the noniparous state. By the end of the first week, the external closes such that a finger cannot be easily introduced. 2. Vagina. The vaginal wall is initially swollen, bluish, and pouting, but rapidly regains its tone. But it does not completely return to its pre-pregnant size, although remaining fragile for 1 to 2 weeks. Perineal edema may persist for some days. Resolution of the increased vascularity and edema occurs by 3 weeks, and the rugae of the vagina begin to reappear in women who are not breastfeeding. At this time, the vaginal epithelium appears atrophic on smear. This is restored by weeks 6 to 10. However, it is further delayed in breastfeeding mothers because of persistently decreased estrogen levels. 3. Perineum. The perineum has been stretched and traumatized and sometimes torn or cut during the process of labor and delivery. The swollen and engorged vulva rapidly resolves within 1 to 2 weeks. Most of the muscle tone is regained by 6 weeks, with more improvement over the following few months. The muscle tone may or may not return to normal, depending on the extent of injury to muscle, nerve, and connecting tissues. Special organ of a pregnant woman. 4. Abdominal wall. The abdominal wall remains soft and poorly toned for many weeks. The return to a pre-pregnant state depends greatly on maternal exercise. 5. Ovaries. The resumption of normal function by the ovaries is highly variable and is greatly influenced by breastfeeding the infant. The woman who breastfeeds her infant has a longer period of amenorrhea and anovulation than the mother who chooses to bottle feed. The mother who does not breastfeed may ovulate as early as 27 days after delivery. Most women have a menstrual period by 12 weeks. The mean time to first menses is 7 to 9 weeks. In the breastfeeding woman, the resumption of menses is highly variable and depends on a number of factors, including how much and how often the baby is fed and whether the baby's food is supplemented with formula. The delay in the return to normal ovarian function in the lactating mother is caused by suppression of ovulation due to the elevation in prolactin. Half to 3/4 of women who breastfeed return to periods within 36 weeks of delivery. 6. Breast. The changes to the breast that prepare the body for breastfeeding occur throughout pregnancy. If delivery ensues, lactation can be established as early as 16 weeks gestation. Lactogenesis is initially triggered by the delivery of the placenta, which results in falling levels of estrogen and progesterone with the continued presence of prolactin. If the mother is not breastfeeding, the prolactin levels decrease and return to normal within 2 to 3 weeks. The colostrum is the liquid that is initially released by the breast during the first 2 to 4 days after delivery. High in protein content, this liquid is protective for the newborn. The colostrum, which the baby receives in the first few days postpartum, is already present in the breast, and suckling by the newborn triggers its release. The process, which begins as an endocrine process, switches to an autocrine process. The removal of milk from the breast stimulates more milk production. Over the first 7 days, The milk matures and contains all necessary nutrients in the neonatal period. The milk continues to change throughout the period of breastfeeding to meet the changing demands of the baby. The cardiovascular system reverts to normal during the first 2 weeks. The extra load on the heart from extra volume of blood disappears by the 2nd week. 7. Routine postpartum care. The immediate postpartum period most often occurs in the hospital setting, where the majority of women remain for approximately 2 days after a vaginal delivery and 3 to 5 days after a cesarean delivery. During this time, women are recovering from their delivery and are beginning to care for the newborn. This period is used to make sure the mother is stable and to educate her in the care of her baby, especially the first-time mother. Routine practices include a check of the baby's blood type and administration of the RhoGAM vaccine to the Rh negative mother if her baby has an Rh positive blood type. At minimum, the mother's hematocrit level is checked on the first postpartum day. Women are encouraged to ambulate and to eat a regular diet. Cesarean delivery. The woman who has had a cesarean delivery usually does not experience pain and discomfort from her perineum, but rather from her abdominal incision. This, too, can be treated with ice to the incision and with the use of systemic pain medication. Women who have had a cesarean delivery are often slower to begin ambulating, eating, and voiding. However, encourage them to quickly resume these and other normal activities. Sexual intercourse. This may resume when bright red bleeding ceases, the vagina and vulva are healed, and the woman is physically comfortable and emotionally ready. Physical readiness usually takes about 3 weeks. Birth control is important to protect against pregnancy because the first ovulation is very unpredictable. Patient education. Substantial education takes place during the hospital stay, especially for the first-time mother. The mother, and often the father, is taught routine care of the baby, including feeding, diapering, and bathing, as well as what can be expected from the baby in terms of sleep, urination, bowel movement, and eating. Provide education, support, and guidance to the breastfeeding mother. Breastfeeding is neither easy nor automatic. It requires much effort on the part of the mother and her support team. Breastfeeding should be initiated as soon after delivery as possible. In a normal, uncomplicated vaginal delivery, breastfeeding is possible almost immediately after birth. Encourage the mother to feed the baby every 2 to 3 hours, at least while she is awake during the day, to stimulate milk production. Long feedings are unnecessary, but they should be frequent. Milk production should be well established by 36 to 96 hours. In women who choose not to breastfeed, the care of the breast is quite different. Care should be taken not to stimulate the breast in any way in order to prevent milk production. Ice packs applied to the breast and the use of a tight brassiere or a binder can also help to prevent breast engorgement. Acetaminophen or NSAIDs can alleviate the symptoms of breast engorgement, e.g., tenderness, swelling, fever, if it occurs. Bromocriptine was formerly administered to suppress milk production. However, its use has diminished because it requires 2 weeks of administration, does not always work, and can produce adverse reactions. Discharge instructions. The mother must be given discharge instructions. The most important information is who and where to call if she has problems or questions. She also needs details about resuming her normal activity. Instructions vary depending on whether the mother has had a vaginal or a cesarean delivery. The woman who has had a vaginal delivery may resume all physical activity, including using stairs, riding or driving in a car, and performing muscle toning exercises as long as she experiences no pain or discomfort. The key to resuming normal activity is not to overdo it on one day to the point that the mother is completely exhausted the next day. Pregnancy, labor, delivery, and care of the newborn are strenuous and stressful, and the mother needs sufficient rest to recover. The woman who has had a cesarean delivery must be more careful about resuming some of her activities. She must avoid overuse of her abdomen until her incision is well healed in order to prevent an early dehiscence or a hernia later on. Women typically return for their postpartum visit at approximately 6 weeks after delivery. No sound reason for this exists. The time has probably become the standard so that women who are returning to work can be medically cleared to return. Anything that must be done at a 6 weeks postpartum visit can be done earlier or later than 6 weeks. An earlier visit can often aid a new mother in resolving problems she may be having or in providing a time to answer her questions. The mother must be counseled about birth control options before she leaves the hospital. She may not be ready to decide about a method, but she needs to know the options. Her decision will be based on a number of factors, including her motivation in using a particular method, how many children she has, and whether she is breastfeeding. A systemic review of ovulation and menses in non-lactating women found that although most women begin ovulation at least 6 weeks postpartum, with mean day of first ovulation occurring 45 to 94 days postpartum, a limited number ovulate sooner. 2 studies reporting earliest day of first ovulation reported it occurring on days 25 and 27 postpartum, emphasizing the need for early postpartum contraception, discussion, and method initiation to decrease the risk of pregnancy soon after delivery. Natural method of menstrual cycle. The following are the available options. They are as follows. Natural methods can be used in highly motivated couples to include the use of monitoring the basal body temperature and the quality and quantity of the cervical mucus to determine what phase of the menstrual cycle the woman is in and if it is safe to have intercourse. Barrier methods of contraception, such as condoms, are widely available, as are vaginal spermicides. Condoms are available over the counter, while diaphragms and cervical caps must be fitted. Hormonal methods of contraception are numerous. Combined estrogen-progestin agents are taken daily by mouth or monthly by injection. Progestin-only agents are available for daily intake or by long-acting injections that are effective for 12 weeks. Intrauterine devices can be placed a few weeks after delivery. Permanent methods of birth control, that is, tubal ligation, vasectomy, are best for the couple who has more than one child and who are sure that they do not want more. The puerperium covers the 6-week period following birth, during which time the various changes that occur during pregnancy revert to the non-pregnant state. Physiological changes during the period of puerperal problem. Physiological changes during this time include common puerperal problems such as perineum. If the perineum has been damaged and repaired, it may cause considerable pain, requiring analgesia, and women may prefer to sit on a rubber ring. If the perineum is painful, it is important to check the sutures and check for any signs of infection. Occasionally, sutures may need to be removed. Micturition. Retention of urine can occur, possible secondary to pudendal nerve bruising, and can occasionally require catheterization. Approximately 50% of women will develop some urinary incontinence, and this usually takes the form of stress incontinence. This may persist after the pregnancy. Pelvic floor exercises should be taught and encouraged. Bowel problems. Constipation may be a problem for a short time, and stool softeners may be useful. Hemorrhoids may be more painful after the birth than before. This can occasionally appear for the first time perinatally, and this normally disappears within a few weeks. Mastitis. This may be due to failure to express milk from one part of the breast. It can be treated by ensuring all milk is expressed and with cold compresses. It may be complicated by infection with Staphylococcus aureus and require treatment with flucloxacillin. Very occasionally, a breast abscess develops and requires incision and drainage. Backache. This may persist after the birth and affect approximately a quarter of women. Pain may be considerable and last for several months. Psychological problems. 3rd-day blues. On days 3 to 5, a large proportion of women become temporarily sad and emotional. Approximately 10% of women suffer from postnatal depression, which may present at any time during the first year after delivery. The precise cause of this is unknown and may involve hormonal changes, reaction to excitement of childbirth, and doubt by the mother about her ability to care for the child. Management consists of reassuring the mother and explaining what is happening. Postnatal psychosis. This affects 1 to 2/1,000 women and usually appears as mania or depression, but women sometimes present with apparent schizophrenia. It usually begins abruptly at 5 to 15 days, initially with confusion, anxiety, restlessness, and sadness. There is rapid development of delusions, e.g., baby has died or is deformed, or hallucinations with deepening melancholia. The woman must be admitted to hospital, preferably with her baby. There is limited evidence for the effectiveness of treatment, specifically for puerperal psychosis. Treatments used for affective psychosis in general are also appropriate for puerperal psychosis, e.g., one or more drugs from the antidepressant, mood stabilizing or neuroleptic groups, and occasionally electroconvulsive therapy, ECT. Postpartum hemorrhage. Primary postpartum hemorrhage is defined as loss of more than 500 ml of blood during the first 24 hours. Normally, 200 to 600 ml blood are lost before myometrial retraction plus strong uterine contraction stop flow. The majority of cases are associated with either an atonic uterus or placental remnant. The rest of cases are associated with laceration of the genital tract, rarely uterine rupture or blood coagulation defect. Treatment in situations where the placenta is still in the uterus is combining controlled cord traction with fundal pressure. If this fails, manual removal of the placenta under general anesthetic is carried out. If the placenta has already been expelled, treatment includes massaging the uterus, intravenous IV ergometrin or cytosine or misoprostol, blood transfusion, correction of coagulation defect by manual compression of the uterus, urgent transfer to theater for surgery may be required. Secondary postpartum hemorrhage is abnormal bleeding after 24 hours up until 6 weeks postpartum. Usual causes are poor epithelialization of placental site, retained placenta fragments, and or blood clots, usually detected by ultrasound. The uterus is often found to be bulky and tender with the cervix open. Initially, it is treated with ergometrin intramuscularly plus antibiotics. Curettage is only necessary if bleeding persists despite this. Postnatal anemia is common and may easily be overlooked. Puerperal pyrexia, defined as temperature 36 degrees C or above during the first 14 days after delivery. This now occurs rarely. Most cases are due to anaerobic streptococci that normally inhabit the vagina. Initially, they infect the placenta bed and then spread either into the parametrium or via the uterine cavity to the fallopian tubes and occasionally the pelvic peritoneum. Alternatively, there may be breast infection or UTI or a non-infective cause such as thromboblepharopathy or deep vein thrombosis. Thromboembolism. This occurs in less than 1 or 1,000 births and is more likely to occur in women who are overweight, over the age of 35, or who have had a cesarean section. Deep vein thrombosis. This is indicated by low-grade fever, raised pulse rate, and a feeling of uneasiness. Raised pulse rate and a feeling of uneasiness. Calf muscles are tender and painful on firm palpation. Clinical signs are unreliable, and the D-dimer cannot be used in pregnancy and puerperium, so confirmation is needed with color Doppler ultrasound. Treatment is with low molecular weight heparin and then oral warfarin, continued for 6 to 12 weeks. Pulmonary embolus, dyspnea, and pleural pain and cyanosis may develop later. Friction rub is hard on the chest. Diagnosis is confirmed by a lung perfusion scan performed urgently, as women may die within 2 to 4 hours. Treatment is with IV heparin bolus, followed by infusion. Postnatal care. Women should be offered information to enable them to promote their own and their baby's health and well-being, and to recognize and respond to problems. At the first postnatal contact, women should be advised of the signs and symptoms and appropriate action for potentially life-threatening conditions. All maternity care providers should encourage breastfeeding. At each postnatal contact, women should be asked about their emotional well-being, what family and social support they have, and their usual coping strategies for dealing with day-to-day matters. Women and their families or partners should be encouraged to tell their healthcare professional about any changes in mood, emotional states, and behavior that are outside of the woman's normal pattern. At each postnatal contact, parents should be offered information and advice to enable them to assess their baby's general condition, identify signs and symptoms of common health problems seen in babies, contact a healthcare professional or emergency service if required. If the perineum is painful, it is important to check the sutures and check for any signs of infection. Occasionally, sutures may need to be removed. Constipation may be a problem for a short time, and stool sustenance may be useful. Hemorrhoids may be more painful after the birth than before. This can occasionally appear for the first time perinatally, and this normally disappears within a few weeks. Summary. In study session 13, you have learned that puerperium is defined as a period which commences after the expulsion of the placenta and lasts up to about 6 to 8 weeks after delivery. Special organ of a pregnant woman includes the following: cervix, vagina, perineum, abdominal wall, ovaries, breast, routine postpartum care, vaginal delivery, cesarean delivery, sexual intercourse. Natural method of menstrual cycle. Natural methods can be used in highly motivated couples to include the use of monitoring the basal body temperature and the quality and quantity of the cervical mucus to determine what phase of the menstrual cycle the woman is in and if it is safe to have intercourse. Physiological changes during this time include common puerperal problems such as perineum, micturition, bowel problems, mastitis, backache. Postnatal care. These are treatment and care shown to a nursing mother and baby after childbirth. End of study session 13. Thanks for listening.